I wanted to just open it by saying, again, thank you for all of the folks that are here that have taken the time to travel and come. I know a couple of you have come a long way, and we definitely appreciate that effort. So it's very great. We probably will do one more steering committee meeting, maybe in September, early October, before the end of this term. But the nice thing about stepping up, as I say when I talk to new counties, we're not from the government. So it doesn't matter what happens with the government. We're going to keep going because we've got a benefactor, Rick Keller and PEGS Foundation, that's not from the government, but we have some great government partners. And we hope to continue all the work that we've been doing, even with any regime changes that happen. So that's a nice thing. Now, I've always introduced Rick Keller before as the president and CEO of PEGS Foundation, but I'm going to do a little bit more than that this time. Hang on a second. So was 28 years in the Army. He began as an infantry officer, platoon leader, and then he joined Special Forces, known as Green Beret, led a Special Forces detachment called SCUBA all over the world, especially in Europe and Middle East and Africa. And then he served at the 10th Special Forces Group headquarters, overseeing all budget and resource matters. And then he served at the Pentagon as Director of Resources for the United States Army Operations and Readiness Initiative. Get this, he supervised an $8.6 billion budget. So we're a little small fry here for him with PEGS Foundation, but he brings a great number of skills and knows how to play on the big leagues with all the national foundations that he's so involved in. So he's had all sorts of combat experience, and of course he's a big veterans champion. He has a bachelor in nuclear engineering, which I relate to because, believe it or not, I started with a nuclear physics major. Long story how I got to law. So I have that we share, and he's been on a lot of foundations. He serves on the Brown James Family Foundation. He does a lot of National Philanthropy Foundation work, and he's president of the Talmadge, who was president of the Talmadge School Board for many, many years. But he's just been a national leader. He's taken stepping up, but mostly clear pathways, which you've heard several presentations on before, to a real new level in working nationally. And so we're so proud to have him here. So he's going to open and talk a little bit about PEGS, and then he's going to introduce our first guest, which we moved up on the calendar because he needs to get back home. And so he's going to introduce our guest after he's done speaking. So, Rick.
So Justice Stratton is really good at embarrassing me. And obviously with current world events, I've got my former service I spent a lot of time in Eastern Turkey and Northern Iraq and places like that. And I guess now the Kurds and Kurdistan folks are now our partners. And they were our partners back in 1991. And I got a text a day or two ago, and it was an interesting text from somebody that I've known for since then, and I'm kind of digressing a little bit, but it was interesting how they reflected on wanting our help for so long. And he's like, "So is this one for real?" And I'm like, "It feels like it." But anyway, not political comment I'm making here though, but I think all of our service members are in our minds as we're in this let's call it war, right? And I know not everyone's probably excited or happy about it. No one's happy about war, particularly guys that serve and are veterans. So just a little thought and prayer for the folks that serve. So I wanted to share, like I always think I come up and I say the same thing over and over again. So I was trying to freshen it up, and was encouraged to, Kathy said, "Hey, send us some slides." I was like, "Hey man, let me bring Peg into the room." So what you see on the screen is to just talk about who we are. We're a foundation, philanthropic foundation. Every foundation will stand up and tell you, "Hey, we're innovative and we're different." Well, if you're all different, then what are you, right? But we feel like we are innovative and we're different, but we're a philanthropic foundation. We have an endowment. That's what brings us to the business side of what we do. And in that work, we think of ourselves as a catalyst to help others accelerate their work, break down barriers, and maybe get outside the lines a little bit for programs that are limited through local or government funding. And we add maybe some icing and some sprinkles around the side to enhance the efforts of those folks. And then first and foremost, really, but the last bullet there is that we come about our work as family, and this is why Justice Stratton Eve is so close to us, has been so gracious in her work in elevating us. We catalyze her through support, sure, but that's the difference that you all ultimately make. So that's yeah, that's who we are. And that's Bert and Peg up there in somewhat younger years. We were founded by both of them in 2001, and we turned 25 years old April 6th of this year. So we're pretty excited about that and have some new things we're doing. Next slide, if we can. And here's just a list. And there's Peg and her son. And I often talk about Dave Morgan and his experience with serious mental illness and schizophrenia and how that shapes and forms everything that we do. A moment of crisis that he experienced where sheriffs would a victim. And thankfully to some smart work by some smart folks. One person in this room is related to a guy named Terry. Got Dave out of what could have been a very difficult situation, maybe loss of life, injury to deputies and or himself, and got him on a pathway to recovery. And he's in a group home in Holmes County doing awesome, and has been since that day. And so that's why you'll hear a little bit from the Clear Pathways folks here. And also the work of stepping up and all this collective work, it matters to us so much because not every family mom can stop what she's doing and go help her son and make connections to folks like Terry Russell. And by honestly some providence and luck and God's will ends up getting her son into a better situation. But that's probably uncommon and it needs to become common. And so on the right, you see different things that we can convene, initiate. You don't see us. We can't provide services. We can't do many of the things that you all do. And that's why we're here in this room as a catalyst. So next. And lastly, I want to say, Peg, I want to say thank you on her behalf. She's passed, in case anyone was wondering if I just saw her. No, she passed almost 13 years ago. And she would be, so everything we measure is like, she gave us this line of think bigger in everything that we do. And so we measure like everything we do by would Peg be proud. And I guarantee that if this person was in this room today and met you all and understood the work that you do, that she'd be super proud. So we thank you. My board thanks you. I thank you, and particularly Justice Stratton, but not just you, but the folks that show up, whether they want to or not. The Velvet Hammer is pretty good at gathering and convening, right? Which is one of our key attributes as a foundation. And then encourage folks in a very positive way to make a difference in what is a very challenging and difficult set of circumstances. Serious mental illness, serious addiction is one of those few health issues that really is super disrupted to individuals, to families. You all know this. And so we're just grateful for all of you. And I think you're back up, or am I still going? Oh, I got to introduce. Yeah. So it's my pleasure. I made a new friend, and I'm going to be 62 in like next week, I think. And I thought I was done making friends. Like I've got enough friends. I don't need any more. But made a new friend last fall. I was introduced to him through a guy named Jonas Tom, who some of you know, and then Luke Russell, who some of you may have heard of. Is Luke here? Yeah, he's here, right? And so I'm going to give you a little background about Anson, and then tease you for why we're partners, friends, and why I think Radley Care is an important endeavor, and he'll share about it. He's co-founder and CEO of Radley Care, leads all strategy planning and implementation. But when you're in a startup, it means you also answer every phone call and you got to go check the mail. It's a startup endeavor that's really taken off, and we're excited about that. He's an experienced executive, successfully founded or co-founded Strive Capital, which is $1 billion plus capital organization, and then had, I think it's Athletic Capital, which was a private equity endeavor. So he's got a lot of experience in how you raise money to create business and accelerate business for return, which is great acumen to bring to the work that we're in. He formerly was president Anheuser-Busch, I think, sales and marketing, which is a big corporate job, And that's the kind of experience that I think is super helpful to the work that we're in, and also helps with the startup that he's going to share a little bit about. And he's got a BA from Yale and MBA from Harvard. And I asked him, like, hey, how should I introduce you? Because sometimes you like brag about folks' credentials or you don't. He's a super humble guy. And he's going to share where the name Radley comes from, but he has a brother with serious mental illness, and I won't take away his story, but sincerely driven in this work in a very sincere way. So Anson, if you would.
Thank you, Rick. I really appreciate it. Thank you, Justice Stratton, for having me today as well. Rick, I really appreciate on your slides as well with PEG's Foundation, when it says philanthropy, what can it do? One thing I have to do is really thank Rick, because on that slide it said invest. And PEG's Foundation has become an investor in actually what we're building here at Radley, which is very exciting. They've become an equity partner in terms of what we're building. And thank you for that introduction as well, Rick. One of the things that you probably noticed in that introduction is there was nothing in healthcare. A lot of people ask me, they say, your background's in Anheuser-Busch and beer, your background is in finance. How did you get involved in mental health and whatever thing's going on here? And Rick alluded to it, but my journey in mental health started 20 years ago. I got the scariest phone call I've ever got in my entire life. It was from my dad. I was a senior in college. My youngest brother was about to become a freshman at Ohio State, and he was in the midst of his first full-blown psychotic break. It was something that our family had never experienced before. There was not mental illness that we knew of in our family in a big way, and probably like most families, we made a lot of mistakes early on. We didn't think that the diagnosis was right. We said schizophrenia, no way. That doesn't affect, just families like us. We were a middle-class family, grew up right by Kings Island down in Cincinnati, Ohio. There's no way that's us, and kind of discounted what was told to us. Made tons of mistakes over the last 20 years as a family. My brother early on probably didn't get the medication that he needed when he was at Ohio State, had a second breakdown at Ohio State. Third one in grad school where he had to drop out of grad school. Fourth one kind of in between jobs. And then a fifth one a couple years ago where my brother, he's now 38 years old, lives at home with my parents on Medicaid. He's on disability. And I used to think that was a unique story. We didn't talk a lot about this, but the more as a family, we started opening up and telling our story about, my brother and what had happened and how, he was really struggling. It was unbelievable to me how the amount of people that have a family member, a friend, a colleague, a relative, and even got to the point where in the neighborhood we grew up in, there's 100 houses, very middle-class neighborhood, and there's 5 people that are just like my brother. Like in this one neighborhood, people in their 30s, 40s, living at home with parents, grandparents, brothers, sisters. And I've always thought to myself, like, man, like, how can we do a better job just like connecting all these people that have decades of experience? There's no better person to help kind of other people on their recovery journey than, mom like myself has been caring for my brother for 20 years. She's read every book. She's read every article, talked to as many doctors as she can. I mean, she's probably more knowledgeable than a lot of people getting out of grad school about what it takes to manage and care for somebody with serious and persistent mental illness. So I've always thought, how do you kind of take all those folks, take that knowledge and really hyper local sort of care for individuals? And for a bunch of different reasons, I was presented with this opportunity. I was really blessed with an opportunity to create a business that does just that. So I'm going to get into it here for a second. I got about a 15, 20-minute presentation to explain kind of what we're building, what we're doing. I'll give a little bit more about my background, but again, just want to thank everybody for letting me share my story today, and I would love your feedback afterwards. So I think do I have a clicker here? Looks like it works. Oh, here we go. All right. So a lot of other folks, again, they ask me, hey, you have this whole background and now you're going into mental health. And with mental health, all you hear about from the outside is it's such a mess. Well, I like running to big problems because that means there's big opportunities to solve them. I've been involved in a lot of big projects kind of historically, been blessed to be part of some companies that were involved in solving some large kind of national issues. But I think the one thing that if you take a look about right now, Rick was talking about the war in Iran. There's a lot of, discussions on both sides of that. The one thing where there's not really a lot of discussion on is like, do we agree that there's a crisis on mental health? And I think that's both Democrats and Republicans alike on the left and right say, man, we're in the midst of a crisis. You watch Fox News, we're in a crisis. You watch CNN, we're in a crisis. This is one thing people agree on, that we all need to work together and find solutions. And that's what I love about a lot of people in this room, that we're all here to find solutions to this issue. Vivek Murthy, who was Biden's Surgeon General, was talking about this mental health crisis that we're in. And then you have Vance last year talked the same thing. We're in the midst of this mental health crisis. Put some numbers to it. I know a lot of people probably know a lot of these, but you have 1 in 5 adults that are experiencing mental illness annually. 1 in 20 are experiencing severe or persistent mental illness, so your schizophrenia, bipolar, deep anxiety, depression. And then I always say this is a young person's illness. 75% of all mental illness begins by the age of 24, and it's lifelong, and it tends to be degenerative. It gets worse, not better, especially if you don't get help and you don't get care. One of the biggest issues, like even with a lot of the investments and dollars pouring in, all the trends are heading in the wrong direction over the last 15 years. If you take a look at major depression episodes in teens, they're up 2x over the last 15 years. If you take a look at ER visits for SMI and SUD, up 42%, and suicide's the number leading to cause of death in the US for people age 18 to 34. We're as a country, we're spending $280 billion a year on mental health and billions more if you think about the knock-on physical and social health effects in this patient population. So people with SMI tend to be at greater risk for things like stroke, diabetes, obesity. They have higher run-ins and higher run-ins with police, higher co-occurrence with SUD, higher unemployment rates. And one of the biggest issues that we have is only about 50% of this patient population is actually getting help or treatment on an annual basis. So big gap to close in terms of making sure people are getting that help and care that they need. We know that there's like a massive need for additional mental health professionals in this country as well. There's 160 million adults in this country that don't have access to mental health care, or that are in what are defined as mental health shortage areas, where there's not enough therapists, there's not enough psychiatrists, there's not enough social workers. And the more rural, the more suburban you are, the more likely you are to not have access. And then also, if you're on Medicaid or Medicare, also, you don't necessarily have access because a lot of doctors only take cash or they only take commercial insurance. So one of the things we're working on with Radley, specifically working on the Medicaid and Medicare population. One of the things we're doing, we're creating a new peer support company. So I'll get into kind of our mission, but our mission is to empower adults living with severe mental illness to live amazing lives. We're doing that by we've created a network of over 400 certified peer supporters across the state of Ohio. We're bringing a lot of people that currently weren't working in peer support and now giving them the opportunities to work. And I would say an Uber meets Match.com model, which we'll talk about here in a second, because we're not just doing online only work. Online only work, it's interesting, but I think it gives more access, but it doesn't solve the outcomes issue. Because unless we're hyper local, walking with people in person, hand in hand, we're going to be disconnected from a lot of the providers that they need to go to, a lot of the social services people need to access, and then also making sure that they're getting connected into Medicaid and being able to pay for the services that they utilize as well. We're doing our business model a little bit differently as well, where I just don't think that chatbots or robots or others are going to solve this patient population anytime soon. I know that if a robot army showed up at my brother's house, that's going to make his problems worse, not better. So that's something that I don't think is going to be solving this patient population's issues. This might solve some issues over, in Iran and what's going on over there. It's not solving our issues that we have here back home in terms of getting people sort of help and care that they need. Mentioned a little bit about my family history. One of the most interesting things, again, going back 20 years, I would have thought that the severe mental illness population, that this is the folks that are downtown, they're urban, they're homeless, they're on the streets. That to me is now, it's the tip of the iceberg. Yes, there's 600,000 people in this country that are homeless, but there's 15 million people that are experiencing severe and persistent illness that look very much like my family. This is a picture of my family. So this is myself, my middle brother, my youngest brother. My youngest brother is there. He's, I think, on the right-hand side. And this actually, 2 or 3 years ago, he showed up with stage 4 testicular cancer on top of all the other issues that he had. And this is something, he was 35 years old and never should have happened, but he wasn't necessarily going to his primary care doctors. He wasn't getting his visits. And then all of a sudden he starts coughing up a bunch of blood one day. And again, 35 years old. Now all of a sudden we were fortunate he was on Medicaid, but CareSource was spending hundreds of thousands of dollars on his cancer treatments, on his chemo. And then he eventually had to have part of his lung removed as well. And then, so this was sort of just another piece to myself of just signs that, man, like how often is this being replicated? This is happening, with my family. How many other families are out there? And again, as we start opening up about this, I went to St. Xavier High School in Cincinnati, Ohio. It's like an all-male Catholic school. There's probably 300 kids in my class, and there are 10 kids in my class that are just like my brother. That's like in my class. And you look at my neighborhood, then you open up with everybody that I talk to. It's like, hey, how many more of these stories are out there? And we got to do a better job of trying to build better networks to better not only help these people improve, but then also how can, at the same time we do that, we're probably going to lower the cost of healthcare. So there was a really interesting thing that happened to me. I was very fortunate to have some entrepreneurial success with a with a former business model that I had, and I was thinking about what I wanted to do next. And I wanted to be essentially use some of this experience that I had. I always think when you start businesses, I always give advice to other people. You do them for three reasons. One, I think most importantly, like, is there an actual big problem that you're trying to solve? And I think within mental health, this is a big problem that needs to be solved. Two, I always say, are you uniquely qualified, where you have some sort of an insight about how to better solve that problem? And I think just from my own family experience, my brother's experience, I have some unique insights about what's worked, what hasn't worked. And then I think the third piece is the timing right. And then the timing, this was, I think, very fortunate myself, but at the end of 2024, Ohio, they changed a Medicaid reimbursement law that is allowing for peer support for people with severe and persistent mental illness for the first time ever. So all of a sudden, when that regulation changed, this to me was kind of, you put together that perfect kind of triumvirate of opportunities where big problem, I have a unique insight to it. And now all of a sudden you can actually create a new business model about how do you deliver peer support to people with severe and persistent mental illness. So we're putting together really this first company in the state of Ohio, and we have an interesting business model I'll talk through in a second here. We're building this army of tech-enabled peer supporters across the entire state, focused on the Medicaid population, focused on doing at-home care for these individuals, which is trying to improve the quality of life of the folks, but then also drive down cost. After that, we're looking to expand it. CareSource is one of our investors and partners as well. You might know they're the largest Medicaid payer in the state of Ohio, but then they also have large presences in states like Georgia, Arkansas, and others. And then long-term, I think there's opportunities to build on top of kind of this peer support network, other social services as well, to really do sort of home integrated healthcare. So that's high level what we're doing. Let me go over really quick from an agenda standpoint. We have, I'll give you a little bit more in-depth. A little bit more in depth about exactly what we're building. I'll talk about some of our technology that we have, and then a little bit of our path forward as well. Cool. All right. I kind of gave you the executive summary. I'm not going to hit this much anymore. The only two other things to really probably mention. Also want to give a huge thanks to Luke Russell and the NAMI folks. When I was thinking about this business and starting, and I talked a lot with Luke, Jonas put us in contact. He gave me a ton of good feedback about what to do, where to work, where opportunities are. And we've really incorporated a ton of what NAMI teaches, especially with family peer support, which we're also doing as well, and seeing a lot of success about getting families more involved in the care as well. And then Talbert House was our launch partner last year. We're now receiving patient referrals from over 10 provider partners, which I'll talk about. We're based here in Ohio, so we're an Ohio-based organization based in Cincinnati. I think that if you're going to, tackle a big problem like mental health, you might as well do it from the heartland. So really excited to be in building this here in Ohio. And when I started in healthcare, I had no idea actually how good Ohio was in terms of the support networks, the infrastructure that NAMI has already built for peers, groups like PEGS Foundation, CareSource is here. So incredibly blessed to be building this in Ohio, and then have found amazing folks to build this with, including Jonas Tom, who's the former VP of Behavioral Health at CareSource, Adam Meyer, who is the former Health and Human Services Secretary in Montana, Kentucky, Rakesh, who lives 5 minutes from me in Mason, Ohio, built Epic's IT systems, which is like the #1 healthcare electronic health records for New York City's hospital system. Mark Murphy, he actually went to high school with my brother. They re-met at a NAMI event, and then Mark has been an unbelievable asset. He heads up peer support for us. He's got an amazing recovery story, and then Mary is our psychiatric nurse practitioner. Here's the problem in a nutshell. Again, we're trying to solve. We know that there's 50% of people out there that aren't getting help and care they need. And that's what's not sort of breaking the cycle, where people and patients are having crises. They're getting admitted to the ER. They get discharged with a patient care plan that can be very fragmented and complex. Where do I get medication? Where do I go for social services? Where do I go for therapy? That complexity leads to low adherence. And then all of a sudden, people are right back having crises 30, 60, 90 days later because they're not getting their medication, they're not getting help, they're not getting their therapy. That's the problem we're trying to solve. How we're doing that is, again, this solution. We're building up. I say this army of sort of peers, this army of frontline supporters that are in every single neighborhood across the state. People like my mom, people like my brother, people like myself, who is a certified peer as well. And we're giving them the flexibility to work kind of when they want. If it's 5 hours a week, great. We'll take an extra 5 hours a week from someone like my mom to be able to help with other people. My mom doesn't want to work 40 hours a week, but does she love like volunteering and actually get paid now to do this, 5 hours a week to help other people? Absolutely. And then we match them. So we're kind of an Uber meets Match.com. So we match up patients with the right peers by collaborating with providers. So we have now contracts, and that we now have partnerships with groups like Talbot House, Greater Cincinnati Behavioral, who are sharing patients and referring patients to us. And then we're delivering the right interventions and activities to directly address their issues. And then essentially what we're trying to do is improve the quality of life of these patients, get them back to their primary care visits, get them their medication, get them to therapy, get them to social services, and helping with things like their rates of employment, getting these folks back on their feet and being good citizens in society here. I mentioned all of our peers. They're all licensed professionals across the state. So I myself am a certified family peer supporter. So these are people that have 40 hours of training in person, 16 hours of online training, and then we're now providing 30 hours of continuing education units for these folks as well, in conjunction with NAMI, doing a bunch of their trainings, and then also with other services like Mental Health America and CareSource and others. The benefits are really across the payer, provider, and patient landscape. So CareSource invested into us. After we kind of showed a study from University Hospitals up in Cleveland, a guy named Patrick Reynolds ran a whole study showing how peers working sort of a longitudinal setting, so working with people over time and spending time with them, that can lead to a 20% reduction in medical spend. I use my brother a lot as an example. Like, can you imagine that if he had sort of a peer that was working with him, getting him to his regular doctor's visits, he still might have gotten cancer, but maybe you would have caught it at stage 1 or stage 2 instead of spreading to stage 4, where all of a sudden it's in his lungs and it's in all the rest of his body. And that's a whole different outcome versus being able to catch a lot of these issues earlier on. We're also helping on the provider side. So one of the fastest growing professions in healthcare is all in behavioral health. You have double-digit growth that's going to be happening in things like therapists needed, psychiatrists needed, social work's needed. And now we're going to be leveraging and augmenting this incredibly latent and talented workforce that's all across the country to be able to provide more help, again, inpatient, and close a lot of the care gaps that are currently out there. And then ultimately, we want to improve the quality of life of patients, which this study at a university hospital shows that, again, if you're walking with people hand in hand, you can improve their quality of life. We have amazing partners. So we've launched so far as an organization, and we're working with community mental health centers. We're working with skilled nursing facilities, hospitals, FQHCs, who are now referring patients to us. And these are just some of the launch partners that we now have really across the state. And we have a backlog of about 40 people that we're onboarding right now. Here's a quick overview of our tech, and kind of more specifically diving down what we do and how we do it. So we built all of our own technology. We have peers sign up on our website. We do all their credentialing, their background checks to make sure that they're all certified and licensed and ready to go. This is in a month or two old. We now have 425 peers across the state of Ohio, and the whole idea is we have them right now in over 70 counties across the state of Ohio. But we're going to be filling this state out by the end of the year. We want to have close to 1,000 peer supporters by the end of this year. And the whole idea is to be able to, again, do hyper-local peer support. What we love about this model that we have, where our peers are independent contractors, so we work with them, we get them licensed, certified, and then we're doing all the Medicaid billing on the back end for these folks. And what's even more important is that if we can match up the right peer with the right patient. So if you're an older gentleman with schizophrenia and was a veteran, great. We have older gentlemen that have recovered from schizophrenia that are veterans. If you're a young female with trauma, we'll match you up with a young female with trauma. The whole idea is to make it hyper local and, again, make that match make sense and be able to walk together. And then we work with providers. I say we're a big one team, one dream approach at Radley. So there's a lot of organizations that they are they want to kind of protect their patients, their clients, so to speak. We like to work collaboratively and be part of a continuation of care, where we say we don't need more assessments, we don't need more treatment plans, we don't need more of that. What we need is actual more people that are doing those treatment plans that are driving outcomes. So we're that partner for a lot of hospital systems and for a lot of our community mental health centers. So those are the folks that are doing the clinical diagnostic work, stating the functional impairment of the patients, establishing sort of the goals. Then we take all that information and we kind of do the right interventions and activities directly related back to that care plan. And then I'll show at the end, we then track our progress about exactly what we're doing, and then show that the patients are on the road to recovery. One of the other interesting things about what we do, which I think is somewhat unique, is we intake, again, a lot of that patient data from our provider partners. One of the things that's really interesting with technology and AI, and I think a very good use case of AI right now, our business model would not have been possible 3 years ago. And it wouldn't have been possible 3 years ago because it would have been cost prohibitive for us to take all that complex patient data and then having to pay doctors to read through patient case files and patient information to understand each individual patient, and then to be able to write down and specify for a peer specifically what should be done. We're now able to utilize AI to extract all of that data and information, understand what each patient's needs are, and use AI to recommend interventions and outcomes that are then signed off on by we have a licensed independent social worker, but that would have been cost prohibitive to do 3 years ago. Now we can do that utilizing technology much more cost effectively and to generate a patient plan that's directly related back to, again, their needed goals and interventions. Then the interventions activities that we do, they're based off the 4 areas of recovery of the Substance Abuse and Mental Health Service Administration. So we're making sure people are making good, healthy and emotional choices. They have a stable home and living environment. They have daily meaningful activities that give them purpose. And then they also have a community of social networks and folks that are working with them. We use a lot of clinical tools and models to baseline patients and where they are. And one of them that I like a lot is the DLA-20. If you haven't heard of that, it's similar like a GAD-7, PHQ-9, a lot of those kind of clinical tools that will pinpoint a lot of hindrances people have to make that recovery journey. So the DLA-20, it stands for Daily Living Activities 20. Pretty simple. It's 20 daily living activities that just any functioning adult would need to be able to navigate. And then it scores those from 1 to 7, 1 being low, 7 being high. And then it allows us to kind of pinpoint what are the exact needs that a patient has that our peers should work on with them. After we pinpoint those exact needs, we do targeted interventions with that patient. These interventions are related back to Medicaid billable activities. So helping people develop new skills, do care coordination, doing education, access and advocacy, or just supporting them on sort of like any meaningful activity that they do. And in terms of how this kind of comes together, so let's assume that one of our providers, HealthSource, which is a large federally qualified health center, kind of outside of Cincinnati, they'll recommend a patient to us that says, hey, there's a deficiency kind of in this health bucket, specifically within health practices. This patient's major depressive. They need to better manage their moods, take medication, attend medical appointments. We, as this federally qualified health center, we don't have the staff, we don't have the folks, we don't have the ability to do this. Can one of your peers really help this person through that? We say yes. So we onboard that patient. We will then do interventions like education. And the specific activities that we might recommend to the peer to do with the patient would be things like helping that person learn the signs and symptoms of their illness, help them understand kind of triggers and warning signs, help them with exercises to ward those off, maybe accompany them to provider visits, be a second set of eyes and ears, and again, walk with them on that journey. And then most importantly, then after every single meeting, we're essentially tracking the progress. Are we doing the things that need to be done with that individual patient? And then is progress being made or not? And so a lot of times patients will come to us with low baseline scores. And then after 6 months, the whole idea is to get people to within normal limits. And then our dream and our vision, I stole this from PEGS Foundation, is that recovery is possible for everybody. So I love that vision. I think that's what you have to kind of believe in for our peers. So that's what we preach to folks, that we want to get people back to these 7s and that recovery is fully possible. We have a pretty cool proprietary technology that does all this. So we have our own website, we have our own app. On that website and app, we onboard patients onto either one, and then we connect them with peers. Those peers, they can have the meetings either on the phone, either on a Zoom call, or they can do them in person. A lot of times our meetings, they start online or on a phone call, but then quickly within 2 or 3 visits, we want people to start meeting in person because we think that's really builds trust. That gets people out of their house. That gets people socializing. That's what I think is building the trust, where we're starting to see some pretty good outcomes. Then we document all the information on the back end. Pretty simple 5-step onboarding process for patients, where again, providers and partners are doing assessments. We're then doing the patient care plans that include peer support. We then receive that information. Our LISW sign off on the interventions and activities. We then make sort of initial phone calls to a peer and say, we're from Radley. We're partners with Greater Cincinnati Behavioral. We're partners with Talbot House. We're going to be doing peer support. We then onboard the patient, connect them with a peer, and have them going. Then that patient and peer, they get together, review their care plans, talk about their goals. Then they have their meetings, document the progress. Then we follow up with our care teams every at least 90 days, but it's usually on a monthly basis. We're meeting with case managers and other individuals that are part of these teams. Cool. And then to wrap it up from just from a paths forward standpoint. So we really started this company at the beginning of last year in 2025. We got all of our OMOS certifications, CARF certifications, Medicaid certifications. We contracted with every Medicaid payer in the state of Ohio. So we service all Medicaid patients. We also service most Medicare patients as well. We've just wrapped up our kind of a seed fundraising round that, again, Pegs and participated in, along with a bunch of other folks across the state and a couple other financing firms. And then we are going to be launching actually in Georgia. Georgia is the next state that we're going to be launching in as well, as we think there's an opportunity to not only do this in Ohio, but we've heard from a lot of different healthcare systems this could greatly benefit other states as well. I mentioned that we have a partnership with CareSource, so I'm not going to deeply dive into this, but one of the things that's nice about our business model as well, we're not reliant on grants, we're not reliant on intermittent funding. We're building this business to be sustainable and building it, I think, in a thoughtful way that it can not only, again, work here in Ohio, but can work outside of Ohio. And CareSource is counting on us to essentially do a lot of the follow-up care for patients to help arrest the growth of just healthcare costs. If we can save one ER visit a year, our services more than pay for themselves. This is something interesting as well. This is not across the country. There's about 40 states where you can do peer support services for people with SMI and SUD. So we think there's really big opportunities as well to, again, expand across the country. And peer support has historically, people love it. It's just never been able to really solve a lot of issues about how do you find peers? How do you get them to work, for you? A lot of them don't want to work 40 hours a week. How do you match up the right patient and the right peer? And these are, I think, a lot of the things that we are solving with utilizing technology, utilizing sort of our contractor type model. And we're pretty excited to bring this to a bunch of other states and also elevate the peer profession from one that's traditionally been kind of non-clinical, that we think now you can almost have clinical type outcomes by really empowering people that have their own recovery journeys, sharing that with other people, and being able to amplify that across every single community across the country. And maybe the last piece is later this month, we're actually kicking off a partnership with the Hamilton County Mental Health Docket and Greater Cincinnati Behavioral. So down in Hamilton County, they have a whole separate mental health court docket. We've been working down there with Gary at the docket where he says, mostly Greater Cincinnati Behavioral, great organization, but they have more, they don't have very many peers. And the peers they do have are more substance use ones. And we have a lot of people in the mental health docket that don't necessarily have substance use, but they have just other, it's schizophrenia, it's bipolar, it's trauma, it's depression. Can you specifically work with us? And so now we're kicking off this partnership in Hamilton County. Very excited about it. There's about 180 people that we're going to have essentially working with our peers as part of their kind of recovery journeys and recovery stories. So we'll be very happy to talk with folks if there's opportunities to potentially expand that to other court systems as well. So that's all I have. Thank you very much for your time. I really appreciate it.
You can see why I was excited to have him come and present with what you can do when you marry some business background with the mental health system is incredible, and how he's developed that. So we're very, very appreciative for that. Some of you might have noticed me with a cane. Lest you think that I'm getting old and decrepit and might retire soon, think again. I got a new knee, so I'm going to be even more dangerous. But this is my second outing, so if I fall asleep up here, someone come gently wake me up and make sure I'm back on track. So I wanted to introduce some new members that we have. Radley Group is one of our new members to our steering committee meeting. But I also wanted to introduce Kathy Harper Lee with the Ohio Crimes Victim Justice Center. She can stand up and wave. So Kathy and I actually have a long history. We go back way back when I was on the trial court, and she was a victim of some sexual abuse in the family. And she was worried that somebody that had done that to her was doing it again, and the local prosecutor wouldn't prosecute because he was a prominent person. And so she ended up getting a system. I didn't know this at the time, but you can hire a private prosecutor that will prosecute it. Ended up, he was convicted of many offenses. And she started, because of that, she started the Ohio Crime Victims Justice Center, the first one in the country. Just on her kitchen table, had no funding, no background, really no real training or anything. And she built this group up bit by bit, person by person, and it's become a national model now, to where she's helped thousands, about 11,000. She's provided legal assistance to 11,000 crime victims. She trains a lot. So if any of you are interested in training on crime victims assistant, she's trained 18,000 law enforcement, prosecutors, judges, and other professionals. She's created the Victims Toolkit to help survivors understand their rights at every stage. We worked together and got the statute of limitations changed. This woman has just been a dynamite force. So I've asked her to join us, and next meeting we have, I'm going to hopefully get her to actually present in more detail on what she does. And then I recently ran into a Brandy Hawthorne with a group called Future Plans, a GRIT project. There are I asked them to join, and they are a workforce development program, nonprofit, a lot of state funding, a lot of partners. They really work on trying to help employment with all the population that all of us deal with. And I recently connected them with the Stephanie Nelson, and I think you had your meeting with them because they can do a lot with the reentry program that they're doing. So we're happy to have them. What has been really nice about I don't even remember how I got connected with them, but they work in a lot of Appalachian counties, and there's a few left. We have 66 counties now, but there's a few left. They've made some great strides in helping me connect with some people and commissioners and sheriffs and that in those counties that we're still trying to sign up. So I've been grateful for that. And then last, we have what's called the Correctional Consultants of Ohio. I was recently at the county commissioner's retirement party for one of their members, and found out that the Sheriff Heldman and Ryan Kidwell, and you will recognize some of the names, John Adams, the former Bureau of Adult Corrections, Kirk Keller, jail administrator of Greene County, former jail administrator John Oliver of Stark County. They have put this group together, and their goal is to help train jails to prevent the problems and liability situation that they are often encountering. So they're providing training based on their decades of experience. So we've asked them to also join us. So we're excited to have some new members and some fresh blood in our group. Also, in case we have any questions when we do the next two presentations, I just want to mention, if you're going to ask a question, please get a mic and speak to the mic. We have a whole lot of people online that are participating, and that number keeps growing. And so they can't hear you if you don't speak into the mic. So we'll make sure you get that. I also wanted to introduce the core team for Stepping Up, because not all you are aware of who they are unless you're working with one of these county visits. So when this all started, Tom Craig was the mental health director at PEGS, and he just retired a year or so ago. But he's been a tireless partner up till when he retired. I think he and I went to every single visit together except one or two when we each had a family issue, and second visits, and then we did the Zoom versions and that. And so he was a tireless partner. So we had a team of two, and then the pandemic hit. And we started adding more people, and we went to Zoom. And thank God we did, because we now have a team of 10 or more. And I can't get 10 people who live in Cincinnati and Cleveland and Akron all to go twice a month to some place, but I can get them all on a Zoom. And our local county participation doubled and tripled because it's easy for them all to come in that county. We used to do a hot lunch that PEGS paid for. And it was hard for some of the judges to get out and that sort of thing. Now, the judges will tell me, well, I got a docket. I'm not sure I can participate. I'm like, I'm sorry. I was a trial judge. You take a lunch break. I want you on there. I need you to talk to the community about your specialized docket. And then when they get on, they won't shut up. So it really is a great chance for them to share what they do with their specialized dockets or their AOT programs or that. So I just wanted to read off our working team, several of who are in this room, so you know them. And while you're at it, there's some green packets in the back. Those are the hard copies, what we call the hard copies of our infographics. The steering committee's in there, a lot of valuable. Yep, she's holding it up. So please grab one. All those infographics are also online on the behavioral health website, so you can download them or forward them to others. But I just want to make sure you're free to take those with you. So Rick Keller, of course, as president and CEO of PEGS Foundation, is our fearless leader. Sunithi Karupu is the director of community strategies and innovation for PEGS Foundation, and she's very involved with the Clear Pathways, who will be presenting again later. Chris Nicastro, who's now Deputy Director of Criminal Justice and Recovery Services at Behavioral Health, who's been a partner, I think, from the very beginning. I've started doing any of this in different capacities. He's a wonderful person to work with. Kathy Yoakum, Criminal Justice Administrator at Behavioral Health, who's also been with us from the very beginning. And she's the one that really helps us put together the steering committee meetings and organizes those. And when we get county signed up, she gets those resolutions and gets a welcome. We've got a welcome coming from our new director, Tia Moretti, for Hocking County. And so she's been very, very helpful there. And then Carol Baden, who is Community Health Advisor for the Recovery Ohio Initiative. I was appointed to that right when the governor first started, and she is our partner on that, and had some great presentations that she makes in these meetings on all the services, and especially some real workforce development programs for dealing with learning how to deal with people with mental health issues in the workforce. And then Lisa Schoaf, Dr. Schoaf, is the Statistical Analysis Center Director of the Office of Criminal Justice Services. Her presentations are always really valuable because they've got funding. They funnel all the state funding, a lot of the national funding. And you should all be on the newsletter. If you're on the newsletter, you'll see she has a regular presentation in our newsletter of what's funding is coming down and the latest rounds and when they're due. And then Luke Russell, Executive Director of NAMI. His dad was my very first partner. I think we went to everything together for all those years till he sort of retired. He's doing some housing stuff now. And then Luke took over and has been equally tireless in being a wonderful partner for NAMI. And then Dr. Ribnick, M. Ribnick, is now the Director of Criminal Justice Coordinating Center of Excellence. They're the ones that are in charge of the sequential intercept modeling, the CIT. She's with the Department of Psychiatry at Neomed, another absolutely wonderful partner from the beginning. And then we have, as the Director for Corporation for Supportive Housing, Leah Werner, and Amanda Rodriguez, who's Program Manager. CSH has been a partner with me way back when I was on the court. I was on their national board for 8 years. I was co-chair of the FUSE program nationally that got started that has helped so many people, frequent flyers of the system. They're a wonderful partner. And then we recently added Angie Lee, who's with the Department of Health, Grant and Resources Department. I highly recommend that you look at her section in the newsletter. I have never seen a more complete list of funding, federal, state, local, foundations, you name it. She puts them into categories so you don't have to scrounge through 400 of them. And she has now joined because she does a presentation in our Stepping Up meetings that covers things that I didn't even know existed. All sorts of corporations that will give you free this and free that and help you, with stuff you need for your mental health people or your courts or whatever. So if you haven't listened to her presentation, I admire that. And then my faithful partner, Kathleen Gallant, where are you, Kathleen? There. You probably are the ones that get the emails from her for my lunches, and she's just amazing. She always follows through on everything that we possibly do. And in fact, when I had my knee surgery, I said, well, okay, all right, let's take 2 weeks off. And then became 4 weeks. Okay, let me take another 2 weeks off of lunches. So I've just started doing the lunches, and she's loaded my calendar up again, bless her soul. So, but I wanted to say for this group, we do 2 Stepping Up meetings. We aim for 2 a month. And they take a lot of work because all these people present and they all go and get local presenters. So the local NAMI person, the local housing person, the local mental health department, the local CIT takes a lot of calls on my part because I work with all the judges and commissioners and the vet part and the sheriffs. It takes me between 25 and 50 phone calls and emails. I never have to ask this group, are you getting your stuff done? Are you making your calls? Are you following through? They're tireless. They are the best. I mean, you've all been boards and different boards and committees, and there's like the doers, and then there's the people that attend. Everyone in this group I named is a doer, and I'm so grateful that they show up time after time for these meetings to make those presentations. So I just wanted to give them a big shout out and thank them so much. So an update on Stepping Up itself. There is a 45-page report. I don't know, Kathy, is this online too, our summary of the report? Is it on the behavioral health site? Yeah. Okay. So I'm not going to go through 45 pages, but just some highlights. Several Years ago, we did a survey to see what was happening with stepping up, and then we repeated that 2 years ago. And that survey was done by the Dr. Melissa Burke and Dr. Stinson and Dr. Grace and Dr. DeCroy, Bowling Green University. It's a program that's offered by the Office of Criminal Justice Services, where you'll have researchers for free work with you to measure something. They don't do real big projects, but they measure how effective is your Stepping Up program, how effective is your victims' rights program, how effective is this and that. And they did a survey for us, and just some quick highlights of all the things that have changed. We have now 66 counties that have signed. Our steering committee is up to 68 members, many of whom are online. Thank you for attending there. Now all the counties get psychotropic drugs, long-term injectables, MAT reimbursed, but have actually now gone to a advanced system because it was difficult for them to pay and get reimbursed. That major increase in specialized dockets. When I started, all the jails were terminating Medicaid, even though we had passed a bill years ago, and it hadn't been rolled out in the jails, only the prisons. So our steering committee got that changed. And now all the jails suspend versus terminate Medicaid. And a lot of them, as a result of that, then had navigators come in and sign people up who weren't on Medicaid before they left. We're working on getting the Veterans Reentry Search System, something that Chief Justice and I have worked on for a long time. It's where you send the Social Security numbers every night of your arrestees to the VA, and they will tell you whether you have a vet or not. And I don't care how robust a system you think you have, about a third of the vets in your system will not tell you they're a vet. And as soon as they're identified, that ping goes to the Veterans Justice Outreach Specialist, who immediately can reach out to them, whether there's a vet court or not, hook them up with services. And so like Ross County had identified 6, finally put in their VRSS, picked up 12 in 24 hours. Butler County had identified 12, put their VRSS system in, picked up 24 in 48 hours. Though every one of those people that are not getting VA services are using your local dollars. So because we've only managed to get about 44 counties to actually do it, we're making it law. Chief Justice and I found out 2 states mandate it by statute. Doesn't cost anything. The VGOs will train your sheriffs on how to do it. It saves you a ton of money, and it's passed the Senate, and I'm going down next week to testify in the House, and it's going to be required that all sheriffs will now do this, and it'll save you money for all those reluctant to do that. Clear Pathways was a huge thing that came out of Stepping Up. Early on, Tom Craig realized the need for crisis work, and I'll say a little more about that later. Almost all the jails now use screening tools when someone comes in, a mental health screen, a vet screen, which, as I just said, is not effective enough. You need the BRSS. And the collaboration that has resulted is just amazing between all these groups and the local counties that we visit, and then all the collaboration that follows after these visits. And then we have the Attorney General Task Force. It's now in its 16th year, hard to believe. 8 with DeWine, now 8 with Yost, 500 members, 15 committees, co-chairs for each of them, and they're the action arm. If you go on the AG Task Force website and look at the 6 reports over these 16 years, it's amazing all the things that they have accomplished and been involved in, like getting the MAT, getting the drug reimbursement really started with them, doing a lot of the housing where you have landlord mitigation fund, landlord reimbursement fund. That's all started with the Housing Committee of AG Task Force. So those things have been just really wonderful to work with. So again, if you want a lot more detail and a lot more data, it's in that report. So now I'm going to introduce our next presentation. PEGS Foundation. Rick, do you want to say anything about them again, or you want me to? Okay, yeah, I think you see. So anyhow, Alicia Smith's going to come up, and Sunithi Karupu are going to come up. You've heard 2 presentations already, so they're going to give you more of an update. But like I said, Tom Craig had a vision for crisis work very early on. That was really one of his passions. He really pushed on it, promoted it. We did a statewide conference years ago, brought Mike Hogan back to talk about it, and it's gone on from there to become a major part of what PEGS does, separate from Stepping Up, but collaborating with Stepping Up, because there's so many issues with crisis response. It's the doorkeeper. It's where you really go first. but it's also, you need long-term solutions when you have a crisis. And so they have done some amazing work. They're now nationally known. They have a lot of national partners, thanks to Rick and his collaboration, and a lot with 988, 911. I'm just amazed every time I hear their presentations, all that they're doing. So I'm going to turn it over to Alicia and take it away.
Thank you. Good afternoon, everybody. Justice Stratton, thanks for always giving us the opportunity to share our important updates on Clear Pathways. And just spoiler alert, this is a request for help and an expectation of outreach to get your help. So I'm joined today with my colleague on the screen, Sunithi Kurupu. She's going to be sharing some updates around our 911, 988 interoperability efforts. I'm also joined in person with my colleagues, Katie Cretella, who's our Assistant Director of Community Partnerships, and Sarah Pierce, who's our Project Coordinator who works in our Project Management Office. And I know there are other folks on the Zoom that are also attending and not participating in today's discussion, but critical to all the work that we're doing. I just have to also say, it's not even shameless, just an affectionate plug, that after 20 years of consulting, kind of rat race, and the outcome in consulting is the financial reward and the supposed accolades that you get from doing the work that you're doing for your clients. PEGS is the first client where the accolades are more about the outcomes and what you get to see done effectively for the people that you care about. So we're grateful, blessed, take to heart the think bigger effort that we just want to make a difference for the people we serve. So grateful for our colleagues, grateful for the foundation and its board of trustees investing in this long journey of work ahead, because this is not overnight work. So with that, I'm going to share some key updates. Justice Stratton shared, we've been on this stage before, so we don't want to keep sharing the same information over and over with you. We'll go rather quickly and happy to answer any questions you have. I'm not going to try to use a clicker because I never get it right. So next slide, please. So I'm going to do a little bit of just level set. Sunithi's going to talk about 911, 988. Rick is going to share some work that we're doing nationally, which we're also grateful for. And then we'll wrap it up, and you're welcome to ask any questions if you have any. Next slide. So Clear Pathways, we are an initiative of PEGS Foundation. Our goal is to accelerate the implementation of best practice behavioral health crisis response services, mainly to reduce the reliance on avoidable hospital emergency department utilization, avoidable hospital inpatient care, and reduce unnecessary law enforcement involvement, especially usage of jails and incarcerations. Next slide. So you probably know and have heard us talk about there are three critical components to an effective crisis continuum: someone to call, someone to respond, and somewhere to go, a place to be safe. We have our reach in all three of those areas, but are spending today to talk about what are we doing in the someone to call space and in the someone to respond space. Next slide. You already know this. I thought Anson's slide did a great job of showing the system under strain. We already know this. It's costly and fragmented and results in exacerbating poor outcomes for the individuals we care about. Our focus is on adults. There are other efforts focused on children's care. Ohio RISE and MRSS are taking up that space well, but we need to focus on the adults. Next slide. One back, please. So our theory of change is that we do our work in 4 critical areas by leveraging key strategies to achieve our long-term outcomes and ultimately achieve our mission and vision. Our key areas are, I can never read. Oh yeah, pilot innovations, build capacity, improve policies, and generate knowledge. Even though we have 4 distinct areas, our work Our work crosses, we can focus on one thing, but then have to depend on another one of our pillars to accomplish all of our work. So it's completely cross-cutting. So in the next slide, I'm going to turn this over to Sunithi to talk about the 911, 988 interoperability strategy. And Sunithi, just a quick mic check to make sure we can hear you okay.
Thank you, Alicia. Can you please hear me? Okay,
Yes, we can.
great. Good afternoon, everyone. It's good to be with you all. So I will talk a little bit about our 911 988 interoperability work. We have been heavily focused on really creating and fostering and encouraging the interconnection and collaboration between public safety answering points, also known as 911 and 988 call centers. Okay, so just a brief overview here for folks who may not be as aware of interoperability and what it means. That's a big word. We define interoperability as formalizing the interconnection between systems, and it goes beyond simple coordination. We're looking at formal protocols, procedures, or agreements that actually enable the transfer of calls between 911 and 988. So what Clear Pathways is focused on in the early phases of our work is we actually started with looking at the SafeCom continuum. And just a little bit of information about what SafeCom is. It's a strategic 5-lane framework, and it was originally designed by CISA, which is the Cybersecurity and Infrastructure Security Agency, to help guide public safety agencies to improve their communication interoperability for emergency management. What we did, though, is that we focused on 2 elements of those 5. And that's to say that we focused on the governance structures as well as the standard operating procedures, because this, in our view, is really where the initial collaboration has to begin between 911 and 988. And it's even more critical for us to focus on these 2 areas in a state like Ohio because of home rule. We know that there is a tremendous amount of decision making and coordination that has to happen at the local level. And of course, because of that, there's also a wide variation of the different types of challenges that different 911 centers face. So things like logistical and liability and technological obstacles in order to even be able to consider transferring calls. So this slide here just gives us a little bit of a timeline of our past work and how it's helped to shape where we're planning to go in the future. So I want to spend some time talking a little bit about this. I talked about the SafeCom strategy, so that's really where we began in 2022. We've continuously refined this strategy through our pilot that occurred between 2023 and 2024. We engaged directly with 5 different sites in Ohio. We focused on developing call procedures for transferring calls from 911 to 988. Through this pilot, we developed a TA, Technical Assistance Toolkit, for interoperability between 911 and 988. We were also really fortunate to have worked very closely with Mathematica through that pilot. And as a result, we were able to actually capture our findings and release those findings in our pilot evaluation report last year. And that was really our focus last year is really to be able to disseminate what we learned and understand how that work can then shape where we are today as we are preparing in 2026 to launch our next phase of technical assistance work in interoperability. Our plan is to be able to engage with 2 cohorts. So that'll be 2 cohorts consisting of 10 sites. And by sites, we mean the 911 sites, though we recognize we'll also be working very closely with the 988 call centers that serve those jurisdictions, as well as local community partners like the ADAM boards. Our focus this year will be on site recruitment, which I'll talk a little bit about in just a minute here. And what we hope to accomplish through this next phase of work is the ability to actually test and refine our TA toolkit. And this toolkit consists of just robust guidance and activities to be able to help guide sites to advance interoperability. We will also be collaborating closely with Mathematica again for this next phase of work as our evaluator so that we can actually produce and share findings. And then next year, we hope to engage 2 additional cohorts And that way we can reach an N of 20 here for our work. And in 2028, we will look to conclude this particular phase of TA, and also be able to finalize our evaluation work, so that we can then look at how to inform where we go next in this space. And I'll just close here with a call to action, which is that we are actively in the process of recruiting sites for our initial cohorts. We're operating on a rolling recruitment basis, but we are actively in the process of looking for sites to basically compose our cohort 1 here, which we're trying to kick off in May. So what I would ask is that if you all are interested in learning more about our IO work, or if you happen to work very closely with the PSAP in your community who might be interested, please do reach out to us. I know we have some printed handouts there that have our QR code. We have a specialized email address here for interoperability inquiries. It's called interop@pegsfoundation.org, which I will share in the chat virtually as well for those who are on Zoom. And with that, I'll pass it back to Alicia to talk about our sustainable funding work.
Thanks, Sunithi. And if you didn't grab a handout, please do. There are 2 different handouts. One is on interoperability, one is on APM. Before I keep going, are there any questions that folks have around interoperability and the work that we're doing? Okay, seeing none, next slide, please. Thanks, Sunithi. So you'll hear some similarities because we have a consistent approach around how we pursue our work. So the other focus area is sustaining funding for adult mobile crisis services, and we're doing that through an alternative payment model demonstration, or APM demo. Next slide. So our purpose for this APM demo is to evaluate new payment approaches with select Ohio adult mobile crisis providers to determine whether implementing a value-based payment model tied to a newly established program standard can improve financial sustainability and service quality. And the punchline behind this is that while Ohio has done a lot of work to understand what the crisis system in Ohio looks like and what some of the gaps are, we still don't have a visible benefit in Ohio for many of these services. So our approach is to use the power of our philanthropic partnerships and resources to invest in understanding what happens out in the community, where can we demonstrate proof of concept, and share those findings with policymakers so that we can already have done the heavy lifting and hopefully have those services be implemented at the state level. Next slide, please. So similar to Sunithi, we've done similar kind of setup here. The work for adult mobile crisis actually began prior to 2025. We started with a 20-state policy analysis, looking at other states, because anytime you go to a state policymaker, they want to know, what did other states do? So we did that already, and we keep it current. 20 states do it many different ways, but that served as the backbone for our having done our due diligence on what represents common practice. We also understand what the SAMHSA best practice guidelines for mobile, or for all the crisis services are, and guidelines are just that. They're not regulations, they're not how-to kits, but we at least had enough information where we pursued what we call different phases, phases 1 and 2 in 2025. Phase 1 was a best practices assessment where we looked at 13 adult mobile crisis programs to determine how closely did they align with the SAMHSA best practice guidelines. Why or why not? There's no reason that they should be aligned because there's no policies and requirements in place that they do align, but we at least wanted to start off with an understanding of kind of status quo. The other thing that we did in 2025 is conduct an expense and revenue tool and analysis where those same providers, where we understood how closely they align with best practices or not, how do they staff their adult mobile crisis teams? What are the common expenses associated with delivering those services? Different program standards or different program approaches, but common elements related to, you have to have people, so the staffing. So who are you using to staff and how much do they cost? What are some of the other non-personnel costs, like vehicles and uniforms and technology. Those were some of the expenses that we wanted to understand. We also wanted to understand the revenue. So not surprisingly, this is a largely Adam Board funded service. And that means that Medicaid, these are some of the activities, many of the activities covered in adult mobile crisis are coverable under Medicaid. Again, we just don't have a visible benefit. So there's variation in how providers choose or not choose to get Medicaid payment for these services. But what that ends up doing is leaving local resources supplanting what federal and other state funds ought to be used for. And we want to switch that balance. Our goal is to make sure that in the future years, Medicaid and commercial insurance are used to pay for at least 60% of the cost of adult mobile crisis services. So in 2026, we're using the findings from phase 1 to phase 2 to launch phase 3, which is our APM demo. The first thing we had to do was create standards. Standards don't exist. Again, using what we cultivated from other states, what we learned from many of you were probably part of the Ohio Crisis Task Force. I think there were over 200 of us who were assembled in various conversations to give feedback to the state on the 3 pillars of the crisis continuum, in addition to other elements. So between that, what we learned in the policy analysis, what we learned in our phase 1 and phase 2, we developed program standards, which are not Ohio Administrative Code. They belong to clear pathways. We're not trying to set up something as substituting state guidance, but our hope is that we, as many of our team members, our former state policymakers like myself, know how to craft program standards that we can use to test out a payment approach with those providers. So right now we're creating the readiness self-assessment so that providers can attest whether they can meet the standards as written. And it's a baseline. Can you meet it or not? But what are some of the supports that you're going to need to be able to do things like meet the staffing requirements, do initial data collection and reporting, bill Medicaid in a consistent way to recoup the costs that are Medicaid coverable. And we're going to be launching in 2026 our kickoff of our adult mobile crisis APM demo with a value-based payment boot camp, just to orient people to what it is that we're doing. Our sites are similar in how Suniti described. We are also working with providers, Adam boards, but in our case, we're adding to the mix an additional payer source, which are the health plans, because together we are able to test this APM model. So demo year 1 is kind of everybody in the pool. Let's get our feet wet and start making sure that we're calling apples and apples and bananas bananas. Second year is we have an APM already designed. So using that expense and revenue tool, any updates to that for this cohort of providers, coming up with an APM model, not a rate, but the model might say, based on how your program is designed, provider A versus provider B, your APM needs to include these kinds of considerations for staffing and overhead, other expenses, and your rate based on those things would be X, as opposed to somebody else's might be X times 3. We also have a core set of measures that we just finalized this week, and those are going to be the types of things that we want to show outcomes against. So obviously changes in utilization. Anson talked about readmission. Those are the things that we want to see make a difference. And we also want to see if we need to increase capacity, or if capacity is sufficient, we just don't have enough resources for providers to deploy the people that they do have just because of lack of resources. So first year is initial data collection. We need the boards to maintain their current level of effort and not assume that just because a provider can start billing Medicaid means Medicaid's ever going to be sufficient as a payer for this current round. Demonstration year 2, let's start using the APM model. In demonstration year 3, let's refine that model maybe based on geographies. This is our way of not doing business as usual. We don't want to do what Medicaid typically does, and sometimes by necessity because they have their own rhythm and timeframes for how they have to do things. We have a different rhythm and time frame. But what we're not going to do is say, well, this service seems like it's close to TBS, PSR, CPST. Let's inflate it by 15%, allow a provider to bill for it on a 15-minute unit. That's not sufficient. But maybe a per encounter, a per run, a per month type of rate is what's necessary. But that's what we're going to be learning about in the coming years. I think that might be my last slide before I turn it over to Rick to talk about some national partnerships and work that we're doing. It is.
You can hang out though, because you got to do questions. So thanks, Alicia. So thinking of clear pathways here for the work in the state of Ohio in partnership with state government and local county level government. We're also part of a 3-state collaborative, and this was born out of an effort that started really in 2018, 2019 to think about how can national philanthropy activate work at the state level. And it's not something that national philanthropy is always really good at. So PEGS Foundation was able to think about, hey, is there a way for local philanthropy to be that go-between, that trusted agent that can drive data or at least help catalyze work in an honest and smart fashion? And so what ultimately came of that was a handful of national foundations came together and across the country picked 3 states to participate in what is now known as the Behavioral Health Emergency Response Initiative, or BERI. And it's Ohio was selected, state of Texas was selected, and the state of Michigan was selected. And the idea was to, some states that were big, medium sized, but that if between the 3 of us, we could do something, we could get the rest of the states in the country to think about doing the work as well. And the effort of, I was going to try and be like good at this. There we go. So again, BERI is a national effort to improve responses for behavioral health related 911 calls and ultimately get folks from landing in the ED or in jails to actual decent care. And that Clear Pathways is the implementing partner in the state of Ohio for that work. In the state of Michigan, it's Wayne State University. It is well known for their social work and connection with Michigan state government and community assessment work. And then Meadows Mental Health Policy Institute is the implementing partner in the state of Texas. And each of those 3 states has a unique, different approach. What Ohio's known for is the opportunity to really think about that sustainable, scalable work. We're also known by those other states and by the national funders as a place where you can get stuff done because there's a heck of a lot of collaboration that's going on. So in a lot of ways, we're ahead of the other 2, but it's not a competition with them. I'll also point out in Dallas, they have an effort called Dallas Right Care. It's an amazing way in which they triage and dispatch through the 911 system behavioral health calls. It's absolutely an incredible model. Is it replicable everywhere in the country? Probably not. But for major metropolitan areas, it's worth taking a look at. And it's something, principles of that work you'll find that in ours here in Ohio as well. It's also important to note that all of the work of Clear Pathways, the 2 specific things that are part of that state co-op, the multi-state co-op I mentioned, Clear Pathways, our effort here in Ohio is to address all elements or most elements of the crisis continuum. So it's not just limited to 911, 988 interoperability or alternative payment models, but those are the focus areas that the national folks have looked at Ohio as a place that can pilot and model. And so that's what I think Alicia, where you heard a lot of the Clear Pathways work focused on today. But the Clear Pathways stuff isn't just limited to that. So what we're looking ahead is, and I think Sunithi did a good job of really that call to action is like, hey, open call to recruit, and I'll double down on that, really encourage folks in this room that have connections, super interested in folks that want to participate in that pilot, alternative payment model implementation. Alicia talked about, I think the backbone, a lot of this stuff ultimately leads to that finance policy that will happen at the state level and at county level, but also nothing is going to make any sense without good data behind it. And so this is a data-driven effort. So with that, I think Alicia wants to answer questions if anyone has any.
Any questions we can answer?
Yes. I don't know if there's anything on chat either.
Not, there's one question.
Resource guide. Just repeat the question.
Do you have a resource guide available for what you mean by adult mobile crisis?
Yes, we recently finalized our program standards and have a definition of adult mobile crisis. What we need to do is socialize that. We have many steps because we don't want to step on their toes or get out in front of anyone. So we have shared our concept with the trade association heads. Next week, we begin our socializing of our approach and some of these terms and more of the 31 pages behind this standards with our providers, the ones that we want to have participate. Same with the actual ATOM boards. And then on March 23rd, we have a conversation with a second conversation with all 7 of the health plans. That's a long-winded way of saying, yes, we do, but I would prefer to hold off on sharing it until we've hit all of our marks. I should also say that this past Monday, we socialized the concept and the idea with folks at the Department of Behavioral Health, just to make sure that there's awareness and mutual alignment and like we understand what DBH is doing and what we're doing.
So when can we expect the resource guide?
You sound like Sarah. So Sarah is the most soft-spoken drill sergeant. So I would say early April, we should be on target to share at least a one-pager with some of the high-level elements of what we mean when we say adult mobile crisis, not just the name of the service, but what happens when you go out to the site, like an immediate on-site response and a non-immediate follow-up, and what all those activities are and who can do them. So Sarah will hold me till April 1st, and then we will have that shared with you. Thank you. Any other questions? Appreciate your time. Thank you, Justice Stratton.
Thank you so much. We are actually running a little ahead of schedule. So when our next presentation comes up, please feel free to take as much time as you need. I saw Terry. Where did Luke Russell go? Did he just step out for a sec? Oh, okay. Just going to give a plug out for that. Is he coming back in? Okay. So anyhow, I wanted to give a shout out for our AG Task Force statewide meeting. We do 2 of those a year also, and we usually feature one of our committees to do so. And this one is going to be on policy and legislation. And we have some legislators that are going to be part of the first panel, and then several providers and partners that work in the mental health field on the second part, talking about policies. There'll be a lot of information coming down about some of the funding changes that are happening at the federal and the state level. So it'll be a really good one. It's in person at the State Law Library where we've been having them, but there's also, again, a Zoom option if you want to attend that way. But we encourage everyone to come to that meeting. It's been advertised several times in your newsletter, and we're hopeful that we can get some people to attend that and have a chance to find out what is happening in all those fields. So there's just lots going on. So if Luke ever gets back in here, I might give him a chance to talk more about it, but I don't see him yet. So we'll go ahead and talk about the next one, which is another sort of an update on competency restoration. I want to kind of give you a little history on this. When I was at the Supreme Court, Melissa Knopp and I worked at starting getting mental health courts and trying to get CIT. And she had started one of the few judges, or she was worked for a judge in Butler County. They started one of the few AOT programs in the state. And when she got to the Supreme Court, she thought everybody was doing AOT. And we found out that most courts were not doing AOT because the way the statute was worded, they all believed that they did not have the ability to do so. So when we looked at that statute, we worked on a bill, seems like decades ago now, which made it clear that judges had the power to do an outpatient assistive treatment program. And then we spent a long, long time working on a bill that talked about how you set up AOT and how you do competency and all that sort of stuff. And one of the things we found out is we wanted to give the courts and the prosecutors the ability to dismiss and refer to competency. As most of you in this room know, because you're all pretty savvy, when you go to a competency bed, they keep you there for 6 months if you're at that level. If you've restored to competency, they send you back. The prosecutor says, well, you've done your 6 months. I don't have anything over you. You're done. Back out in the street, no services. If you are not restored to competency, it goes back to the prosecutor. Prosecutor says, I'm done. They've got their 6 months. I can't hold anything over them, and dismisses, no services. And so they cycle, as you know, cycle over and over and over. So looking at some other states and other things done, we got a bill passed that allowed them to dismiss the charges and send it over to the probate court to do an AOT. Well, the problem with that is most probate courts didn't have an AOT. So that was a very difficult thing to do when you didn't have an AOT program. So we worked on that for a while and got a bill passed that Dr. Gordish and many people were involved in. It went through 24 iterations, I think, with our legislative sponsor before we passed it. And I know that they're working on some revisions of it. So I'm hoping that she can bring you an update on that. So it's been a long process because we don't want to just dismiss and have them back in the system. That's the worst thing that we can do. We need to connect them with services, which is a real opportunity for AOT. Well, I'm going to digress for just a second and give Luke a chance since he's walked back in. Luke, I gave a plug for our March 17th meeting. Could you just give a little update on what is going to be covered by that? And then we'll go back. Wait. Got to have a mic. Yeah.
Yeah, our aging task force, criminal justice mental health, and so legislative and policy committee will be holding a 2.5 hours. I think we're going to have a legislative panel. We're going to have an expert panel on just the impact on the legislative and policy work that's being done and how it can help divert people from, crisis. So hopefully we'll be able to, we're going to bring providers in. We've got a couple other folks on my panel that I'm moderating that are kind of NAMI type partners, and the way we work with them to make sure we try to get people diverted from, incarceration or law enforcement detention to mental health treatment. So that's our hope.
Thank you.
Yeah. So.
Yep. And I'll be in your newsletter again. It has been in your newsletter with all those details and zooming in if you need to. So going back to AOT. So as you know, a lot of laws are made based on one incident. And this happened recently. We had some bad incident, I think up north. I won't say necessarily where, and they wanted to extend the time you could be held in a competency bed to 5 years. Well, many of you remember a year ago, February, the governor was here speaking, and the governor found out that like 90% of the hospital beds were taken up with forensic patients, and he got all excited about it. So he announced the formation of a committee to deal with that problem. And for 6 months, we met every other week, faithfully, like the governor likes, came up with a bunch of reports and everything. And unfortunately, a lot of it did not get implemented by the legislature in terms of funding, but some of them did. But that didn't mean we couldn't still make progress on others. But that bill did pass, I understand, in a little different form. So if you can bring us up to date on the history of that and what came from that. And you've got a good 45 minutes to take because we're running, like I said, a little ahead. So feel free to take as much time as you need to explain this.
Good afternoon. My name is Kiana Pearson, and I'm with the Supreme Court's Office of Court Services. And as Justice Stratton mentioned, the governor's work group issued a good amount of recommendations, one of which was to increase awareness in the use of assisted outpatient treatment for our probate courts. And not many probate courts had OAT or AOT, as she mentioned, and Melissa Knopp found out when she came to the Supreme Court. And so we've been working diligently over the last year to increase awareness and education for our probate courts. One of the things that we did is we established a rule. So it gave rule superintendents to give probate courts some guardrails under which to create their program, identify a local rule, have eligibility criteria, data collection, evaluation to ensure that their AOT program was getting the outcomes that they had intended. The next step in our process is to train our probate courts. So in the beginning of June, we're going to be doing a team-based training for our probate courts. We're asking them to bring their AMS boards directors, prosecutors, if they want to bring a muni court judge, behavioral health, and other community partners to come together to understand what AOT is, why it's beneficial for their community, how do we collaborate and design a program, because we know 88 counties, 88 different ways. And then talk about if you are going to do the criminal case dismiss and then provide the services through assisted outpatient treatment, what does that collaboration look like? And then also some of our judges, as they have been implementing and creating their AOT programs, they found it challenging to explain to their community partners exactly what AOT is. So we've developed a training that we're going to be delivering in June, and we're also going to be rolling out our AOT toolkit. So again, some practical strategies on how to create a program, things to think about: who are your partners, who do you need to have involved, and then also again, that criminal collaboration, and then a bunch of forms, example forms, because our courts love when we give them samples so they don't have to reinvent the wheel. So we're very excited about the toolkit. And then we also have recorded a video that we're going to make available to our probate courts to put on their websites to show commissioners, community partners. And so you're all going to get to see our video here. So Brianna?
My daughter, she was 17 when she first started hearing voices and seeing things. It was
how the video turned out. And you can see it's very compelling when you hear directly from the participants how beneficial AOT has been. And so we are bringing one of the participants to the probate conference. And so we're hoping, and he's going to start off our training. So we're hoping that that will really make an impact to our judges. So thank you, Dr. Gordish.
Thank you. And wonderful, wonderful work Kayana and the work group's doing on developing these, the trainings, the supports, the toolkits to help additional judges really understand the value of AOT. I'm Dr. Lisa Gordish. I am Director of Forensic Services with the Ohio Department of Mental Health. Ohio Department of Behavioral Health. We had a name change last fall and I'm still tripping up. So I just, today, Justice Stratton had us assigned for some brief updates, and I will expand on that a little bit. So I did not do slides. My apologies there. To continue with the theme of AOT, one of the decisions in the Department of Mental Health or Department of Behavioral Health has been to allocate some dollars specifically to assisted outpatient treatment programs. So we did just wrap up a process of putting out a request for applications to our probate courts in the amount of $500,000. And we're reviewing those. We're right in the process, right in the middle. And our intent is to have that completed internally and then hopefully announcing those awards in the next week or so. And the real focus of that application was to support existing AOT programs, help them expand if that's their vision, and also potentially to develop new programs. It's interesting through that process, we're really hearing and learning from the assisted outpatient treatment programs some of the needs of the programs. And a lot of the needs are certainly around staffing, things like supporting the non-billable services, supporting peer support in their programs. They, as you heard on the video, are really engaged and interested in seeing their participants do well. So many times it's about providing incentives and rewards for, being compliant and following through and showing up, and really engaging in their recovery. We also heard about evidence-based practices, things like the Wellness Recovery Action Plan, the WRAP program, that can be incorporated into the AOT treatment courts and processes. So really excited about where we're headed with the assisted outpatient treatment in Ohio, and happy to support those efforts. Next year, the department is looking at increasing that to the $1 million, so we can hopefully support then additional AOT programs than what we're able to this go around. So any questions on AOT? That'll wrap that up. Yeah. Yeah.
Today, a lot of this information my first time I had no clue of, and my son and my best friend's son, I'm in charge of both of them, and they both live with schizophrenia. And my friend passed away, and her son is an adult, and he's homeless. And so with this AOT, how do you get, he has not been to prison or jail, how would I get him involved in a program such as this?
So I'll answer, and then if anyone else has thoughts as well. My first thought is your local county ADAM board, your mental health addiction treatment services board, recovery services board. And it is a probate process. It is a civil commitment process through the probate court. So I think both of those resources locally could let you know if your county has an AOT program. Hopefully they do. And oh, good. And then how to link up to that locally. Anyone else have a response in the room? You wanna? Okay. Yeah. Yeah. And if you don't get what you're looking for, contact me and we'll go from there. Did you? Okay.
The video was on the DBH, is the video on the DBH website? That was my only question.
To my knowledge, no, Kayana. Is it?
So the video was recorded by Ohio Government Channel TV, who is part of the Supreme Court, or we have staff. And so our goal is to roll out the video at the probate pre-conference and then make it like publicly available at that point in time. So June, for those of you who are interested.
Great. Okay, so I'm going to move into the territory of competency to stand trial. And if you know me, this is the world I live in with public forensic mental health services and system around those individuals that do get charges are going down the criminal justice pathway. And one of the things that can come up for them is an awareness that maybe their mental health state is not well, is so off, often at the point that they're coming into the jail, that the attorney's talking with them and saying, I'm not sure my client is competent to go through the trial process. And in the statute, it's really looking at, do they understand the nature and objectives of the proceedings that they have to face? And can they assist their attorney in their defense? So the idea is we really don't want to put any person through a legal process who doesn't have the wherewithal to understand that process and to know and be a part of that process. So there are systems in place to have attorneys file motions for competency evaluation. Those evaluations get affected. That person, if they're deemed incompetent to stand trial at that point in time, it's about their present mental state at that point in time, we'll go through a process of treatment. And that treatment's really focused on twofold, often primarily medication to stabilize the symptoms of their mental illness and get them to a place where they can comprehend and move forward. And also education about the court system and really understand the basics, what a plea is, what a plea bargain is, what a judge does, what their defense attorney's role is, what the prosecution's role is. So they can really be a party to that process going forward. With the process of competency restoration treatment, there's traditionally only had been one place to receive restoration, and that was in our state psychiatric hospitals. As you heard Justice Stratton mention, the judge or the governor's concern with the rise in competency restoration referrals, the number of people needing that service, it really did squeeze out the access in our state hospitals for folks that are in crisis in the community and needing that stabilization care that don't have charges. So, a lot of the efforts have been focused on looking at diversion away from criminal justice and into mental health treatment, and also a continuum of services for competency restoration treatment. Does everybody have to receive a hospital level of care to be restored to competency? And what we found over the last several years, Justice Stratton mentioned working on Senate Bill 2, which was put into place 4 years ago now, 5. And one of the aspects of that was to upstand some outpatient competency restoration treatment. So we have 10 programs around the state funded through Ohio Department of Behavioral Health that for certain individuals, and particularly they're individuals that the legal system's confident that they can put on bond and put out in the community, and that they have enough supports that they will comply with and work with an outpatient treatment process. It's not for everybody. We have certainly individuals that are so severe in their illness and in their compliance that they cannot get that service on an outpatient, and they really do need a hospital level of care in the state hospital. But I call those bookends. So you have the most restrictive, kind of highest level of care with our state hospital beds. And then you have outpatient restoration treatment, which it really takes a lot of support to live in the community and do that process as an outpatient. And somewhere in the middle lies the need for a secure ability to do competency restoration and provide for the medication and the structure needed for that restoration, perhaps not at the hospital level. There are some individuals that don't quite need the hospital bed, but they're not eligible for bond. So we did start a pilot of jail-based competency restoration about 2 years ago now, and that's Hamilton County. I was really pleased to hear Anson talk about his connection with the court clinic down there and Gary with their mental health courts, because I'd love to see the peer connection in with the jail-based pilot program they have there. So the jail-based pilot program has really given us some data and some understanding that competency restoration can get people treatment earlier while all of these individuals are waiting on the state hospital bed, because as we were mentioning, the beds are so full, there's a wait list. and go ahead and get that medication treatment to individuals. And many of them were able to get restored before needing that hospital bed. So we were seeing there might be a place for certain folks to be able to receive secure competency restoration treatment, whether it's in the jail or some other type of facility, and looking for opportunities to build out the continuum of places for competency restoration. So we get the right person in the right treatment pathway along the way, and use those hospital beds judiciously and for those that really need that hospital level of care. I think anybody that perhaps needs a involuntary medication process to get restored to competency needs a hospital level of care. You won't see the desire or the ability really to do that at other places. So as Justice Stratton mentioned, very recently a new bill was signed. This is Senate Bill 295, and Governor DeWine signed that on February 20th. And it affects these competency restoration statutes. It's 2945.38. There's a primary one that they really tackled. And the focus on this bill was on expanding the time frame for competency restoration, particularly for a very small set of folks. This is going from the 1 year of restoration to 3 years of competency restoration for those that have charges of murder, aggravated murder, or any charge that could get a life sentence. So for those individuals, there's a strong need to be sure we are doing what we can to restore their competency so they can engage in that criminal justice process. On the other end of the spectrum, I think, are the folks with misdemeanor charges that we talked about the initial bill. Those with nonviolent misdemeanor charges have that opportunity to have their charges dismissed, moved to probate court, and hopefully into treatment through AOT or other supports. And so, it's one statute, but it plays out very, very differently on different ends of the spectrum. So also for Senate Bill 295, the parameters that changed a bit is that the treatment facilities that are affecting competency restoration treatment, if they have a defendant that is refusing medication, is refusing treatment, that they now will toll the time. They'll stop. That clock was ticking before. They had 1 year, and if they refuse medication and it took a couple months to get through the court process to get the order for involuntary medication and affect that order, that time, used to cut into the full year of restoration treatment that you had. Now that time will toll, it will stop until they get that medication order and treatment starts. And then we will have time to work with individuals through that process. The other piece of the change is sometimes we do have individuals that receive treatment in our state hospitals. They look great. They respond well to medication. They become confident to stand trial. They return back to the jail setting and at that point maybe refuse medication again and start to decompensate. So if that were to happen, that time clock restarts at this point, that's now in statute. They can come back to the hospital, receive the full amount of time for that competency restoration. So those are the main highlights of the new bill that went through. And we are actively working internally on our policy and updates and practices for our state hospitals to align fully with the new bill. Any questions on that competency restoration, changes to statute, the difference between some of the high felony and the low nonviolent misdemeanor pathways or diversion? All right, then I just have one more update. Judge David Brannon and I run a AG's task force on competency restoration and diversion. And our next meeting will be March 19th from 1 to 2 p.m. We will be taking on a focus for the next 2 meetings on juvenile competency evaluation and attainment processes, and also crisis response and transitional care. So if you're interested in that topic, shoot me an email. We'll make sure you get the invite to that meeting. Anything else? Thank you.
Thank you. I wanted to just really thank the Supreme Court again for taking in AOT. Melissa and I worked for years trying to work with Treatment Advocacy Center to try to get AOT going, but they were more treatment oriented and didn't have legal staff, and it was difficult to get the judges on board. And so once the court took it in and looked at some of the issues and the protections, it was really very helpful. So thank you for doing that. Our next presentation is on housing. Housing has been near and dear for me from the very beginning. When I was having what I call my kitchen cabinet, we recognized very early, these different agency directors I was meeting with, that everybody needed a house. And we were all stealing each other's houses because we didn't have as many houses and things like that. So we were we worked very hard with Corporation for Supportive Housing to get some housing issues going. Peg's Foundation, when Sally Lucan retired, hired her as a consultant to work on housing. And then the Corporation for Supportive, I was like I said, on the national committee for about 8 years. And then we now have the Corporation for Supportive Housing headed by Leah Werner and Amanda Regis, our people that are on our steering committee, our core committee. And so they're going to talk a little bit about where we are with reentry and housing. I think there is a slide presentation she has as well. So we'll talk about that.
Thank you, Justice Stratton, for inviting us. My name is Janae Jenkins, and I am the Senior Program Manager for the Community Transition Program. And we also oversee what's called Returning Home Ohio. And I want to say hi, Chris Galley, because he has been a big supporter, and Chris Nicastro, if he was still here, for the Returning Home and CSH program. Can I say next in you? So first about CSH, we're a 501c3 nonprofit corporation that we are a national intermediary organization and CDIF that advances supportive housing as an approach to help people thrive. Since our founding in 1991, CSH has distributed more than $1.7 billion in loans and grants that has created over 467,000 homes for individuals and families exiting long-term homelessness. Next. So what is supportive housing? Supportive housing is affordable housing where supportive services with providers actively engage tenants in flexible, voluntary, and comprehensive and work with property and housing management to support tenant stability and ensure that the housing remains a positive community asset for the long term. So what exactly does that mean? It is affordable housing that is permanent and independent. It is flexible, it's voluntary, it's tenant-centered, and it has coordinated services. Our providers provide case management, substance use treatment, mental health services. It provides primary health care services, linkages to those things, parenting, coaching, and life skills, and employment services. So imagine you have someone who's coming out of incarceration who went in when they were 18 or 19 years old and they did 30 or 40 years in prison. When they come out, they're not going to have those basic life skills of living on their own. So we have case managers that walk side by side with them to help them be successful in reintegrating into society. Next, please. So what are some of the housing challenges for the clients that are reentering population? One of the big ones is access to shelter as soon as released from prison. What are some of the barriers for that? Lack of resources. One of the resources you need in order to get in the shelter is to be able to call and get on the waiting list, 211. Well, if they don't have access to phones, how are they going to call to get on the waiting list? Another one is birth certificates. If they don't have birth certificates, how are they going to get their IDs? And then in turn, how are they going to be able to get driver's license and so forth? Disconnected from social supports. That's huge. So a lot of times when they are incarcerated, they may have lost their loved ones or they have burnt bridges before they went in and the loved ones no longer want to deal with them. So they don't have any social support. So it's really important that we help them to develop social supports. And then, of course, exclusions due to law or policy. So one of our major ones is sex offenders, being able to find somewhere to live in certain areas. And also arsonists, being able to find landlords that are willing to take them and insurance will cover it. Next slide. In 2024, we partnered with Invisible People to do a documentary on our programs. And I'll talk a little bit more about the program, but I did want you to I'm going to show 3 snippets during this presentation of the documentary so you could see exactly what we do as an agency. This documentary, this portion of it, you will hear from a couple of the clients and from Leah Warner, who is our director, and Terry Power. If you could start the video.
The U.S. continues to lead the world's incarceration rates.
More than 600,000 people are released from prison every year. Another 9 million cycle in and out of jail.
And for too many, release day comes with no job, no ID, and nowhere to go.
Experts say without support, the cycle often begins again.
But in one state, this program is changing what reentry can look like.
Returning Home Ohio, a program to help formerly incarcerated people to keep them from ending up on the streets homeless or going back inside.
They do this by starting with a revolutionary idea: housing.
I had a bad upbringing. I was never in a place longer than 6 months at a time.
Within 3 weeks, I had my first house.
Invisible People traveled to cities across the state to hear from people living this story.
July 3rd, 75, I went to death row. Come out in 2005. It was a whole different world.
When I got out of prison, I had nothing.
I was involved in an arson, attempted murder charge, actually.
We might have 10 to 20 vacancies at one time. We know that we can call our partners in these programs and say, hey, we're ready to rock.
To build a new prison in the state of Ohio, over $1 billion.
We sat down with the individuals rebuilding their lives and the team that's walking beside them.
Just because you made a mistake doesn't mean that you should be thrown away.
Nobody would take her on, so that made me even more nervous.
Without housing, they can end up homeless and more likely to commit crimes.
I have great remorse for what I did. I love the person I killed.
How much do you think housing helped change your life?
If it wasn't for this housing program, I'd probably be out there getting high right now or back inside, real talk there, yeah. I actually know I'd be dead. I'd be dead.
Where do you think you'd be?
On the street. Back under the bridge or in prison. Ain't no doubt about it.
I honestly probably would have still been on the streets. Going back on the streets, you're going to end up failing.
This program gave me a chance.
I'd have went back to drugs. I know I would have. This is what I got. I live here, you know what I'm saying? And everything else comes from this. I got a steady life. I know I do it. It's like a routine. To keep this, you gotta do this. You gotta do, you know, all that shit you were doing before. You know, you got a lot of friends still doing that, and they're sleeping in the streets right now. You know what I'm saying? And going to prison, and you know, This here saved this saved me and she saved me. But this here gonna be a place, I got a place to live and I work from there, you know, and anytime, any help they give, you know, like I try not to ask for much, but they help me out a lot, Tower House does.
Supportive housing is a non-time limited housing for individuals who can't afford housing on their own, but then it's services.
So that's a little snippet about the people we work with. And I want to talk particularly about the one that had on the cowboy hat. I went to see him 2 years ago. He was a part of the community. He's a part of the community transition program. I go out once a year to all of our providers across the state, and I do what's called a site visit. And during that time, I asked to go out to some of the clients' homes so I can meet with them, talk to them, see how the program's doing for him. And I went out to his home, and when I walked in, I was in shock. The whole house was painted in black, and he had written names all over the walls. And it was very dilapidated. And I said, why do you have these names on the wall? He said, these are all people that have died that were my friends, either from drug overdoses or murder or whatever the case may be. And the house was not in good condition, and he was on a month to month. So I spoke with the housing provider. He said, I can't live here anymore. I'm gonna die. And I said, oh, wow. So I talked to the housing provider and I said, we need to move him. And so they moved him out into an area where his mother lives, where his supports are. And he now, as you see in the video, has changed a 360. He now is clean, been clean over a year and a half. When I walked in the door, he ran up and hugged me and said, if you hadn't have done that, I'd be dead. And we hear stories like this all the time because supportive housing does work. Next slide. So Ohio, did we pass one? Go back one, please. Yes. So CSH oversees two programs, the Returning Home Ohio program and the Community Transition program. So the Returning Home Ohio program started as a pilot. Justice Stratton had a big part of in 2007. In 2012, it became an actual program, and it is funded through the Ohio Department of Corrections. And then Community Transition Program was started in 2017, and it is funded through Department of Behavioral Health. These programs, we do permanent supportive housing, which is not time-based. We work with the landlords, we work with the providers that we have across the state, and it is evidence-based. For it to be a participant in Returning Home Ohio, they have to live with a severe, persistent mental illness coming out of prison and going to be at risk of homelessness or be homeless. And then the Community Transition Program, they have to have a substance use disorder and attended some type of recovery classes while they were incarcerated. They have up to 120 days post-release to qualify for our program. Next slide, please. So what is CSH's role? We are the third-party administrator. We provide specialized standardizations. We do trainings, orientations, technical assistance to the grantees. We enhance and expand programs across the state when funding is available. We manage sub-awards throughout the state. We monitor finances, budgets, and expenses. We do quality improvement and monitoring for the fidelity of the program. We measure the outcomes and the occupancy. We do annual evaluations, on-site monitoring, data collection and analysis. We do client visits and surveys. We provide communication and outreach. We do grantee meetings and trainings. We do prison staff outreach and training. We manage the referrals, and we also do quarterly reporting to the state. Next slide. We're going to see another portion of our video documentary.
People will be more likely to reoffend, more likely to commit crimes, more likely to be homeless. I can't think of a better way that we could help them be successful.
In the folks that we serve, we see the improvements in physical health, mental health, reunification with family members. And their number one goal is to not go back.
that the freedom that they experience, the sense of wholeness and wellness that they experience in community is not worth losing.
I want to better myself. I don't want to sit in prison for 5 minutes, let alone 5 years. I can't even put into words what I felt like when I was in there. You're degraded, you have no freedom, you have to ask to go to the bathroom, you have to ask for everything. They tell you what to do from the time you get up in the morning to the time you go to bed. You just have no control over anything.
You did 11 years?
11 years. It's hard to be away from your family. It's hard to be away from your family and your friends. And then you find out that you don't really have many friends. I was involved in an arson, attempted murder charge, actually. Nobody got hurt, nothing actually happened, but we all paid for it as though something did happen. And in all rights, we should have. Had the alternative happen, somebody could have died.
Me taking on a chance of bringing on somebody that has an arson charge, I haven't had anyone that had such a history, and nobody would take her on. That made me even more nervous. Like, well, why isn't anyone else, like, you know, considering her? But I did take that chance.
Well, isn't it a risk for any time you rent to somebody?
It sure is. I want to say with this, at least you know that you have somebody that is interviewing these tenants before you even got to interview them.
It's kind of like having a management company.
It is. It's a built-in management company. You don't have to pay for it.
Taking a percentage.
They're not taking a percentage. They are definitely there to be that second set of eyes. I don't have to worry about rent being late. If, you know, we're going to be honest here, you have to have a heart to want to help people out. I want to say that for sure. You just got to get comfortable and build that relationship up. Just because they had a past 10, 15 years ago does not make them who they are today.
Yes. Thank you. So as you see, you collaborate with different landlords. It's a collaboration approach. It's a team approach with landlords, case managers, the client, and any other services that the client may need. We had a gentleman who was in the program, who's still in our program, who has 9 numbers, meaning he had been to prison 9 times. So when I went out to his home and was speaking to him, he's been in our program 3 years. He's 64 years old. I said, what is the difference now than before? And he said, this is the longest I've been out of prison since I've been an adult. I said, well, what's the difference? He said, because I have somewhere to lay my head. I don't have to go back in the same environment, and I don't have to worry about where I'm going to sleep or eat. And I have the supports I need, which I've never had before. So the program works. So why do we do this? We do it because we want individuals not to recidivisate back to prison. We want them to be self-sufficient. And so I just want to go over a little bit of our statistics in 2024 and 2025, so our fiscal year 2025, we had an exceptionally low recidivism rate to prison. We only had 2, and for CTP, 2 out of 173 participants exiting our program to go to prison, which is a 1.1% recidivism rate. We had 4 individuals exit to jail. This works because of the supports our clients get on a daily basis from our case managers, from their outside supports. This program works. It cuts the public safety costs, it cuts the institution costs, and it works. We'll go to the next slide. The RHO recidivism rate for fiscal year 25 is they had 228 participants, and out of those 228, they only had 10 exit to prison, which is 4% exited. Majority maintained their community stability. And 5 individuals exited to jail, which means 2% went back to jail. If we could hit the last part of the video, please. So who pays for this?
We did one.
Offsets, agency's voice, benefits of the program. If you could play.
Wonder though, who's paying for these subsidies, and is it the smartest path forward?
So the justice programs that we administer is paid for with a contract by the Ohio Department of Rehabilitation and Corrections. They pay to offset the cost of rent. The tenants contribute 30% of their income to housing. The contract with ODRC also pays for the critical supportive services, which is the secret sauce in assuring that folks have what they need to not return to prison.
The recidivism rate for individuals in our current program is about 1.4%. We know that numbers for individuals who don't have these supports are much higher. Working at the Department of Mental Health and Addiction Services and the Bureau of Criminal Justice, we have our community transition program. We partnered with the Corporation for Supportive Housing because we saw the results of what they were doing with their permanent supportive housing program.
And the truth of the matter is these systems are taxpayer funded. So why wouldn't we put the right money in the right pot, right? We know it works. We know it stops that revolving door back into prison while improving public safety and improving the lives of folks with justice-involved backgrounds.
You might not like some of these people, but they have paid their debt to society according to our laws. What I know you won't like is homelessness growing. One of the growing causes of homelessness is people leaving an institution, mostly jails and prison. We need to keep them from ending up homeless, and we need to not have them go back inside, which is extremely expensive to taxpayers.
Prisons across the country are bursting at the seams. The quote to build a new prison in the state of Ohio was over $1 billion. Do we want to spend over $1 billion to build a new prison versus investing in supportive housing that costs between $15,000 and $20,000 a year to house somebody in a supportive housing unit? Whereas the cost to incarcerate one single person is over $30,000 a year and growing.
Thank you. So because of the programs, we now have other states that are interested in replicating our programs. And right now, Illinois is actually in the implementation stage. They're actually, I think, started this month, doing a version of RHO. And then we have California, Nevada, and New York, who all four are interested in replicating our program. We also have other states that have been interested, but those are our 4 target states that we're working with over the next year or two. In the last part of our video, if we replicate these programs across the nation, the recidivism rate will go down across the nation. We are 1.4%, which is very, very low compared to the percent for the state. And it's because we provide the supportive services. Our case managers care. They're providing hope for individuals who had no hope.
Having these things in place humanizes the person. It makes them proud of what they have, the fact that they have a roof over their head, and the fact that they can clean their home and pay their bills. I mean, it gives them a sense of self-esteem and accomplishment, and it helps them be successful.
We're in the people business. When you actually meet somebody, you recognize they've got needs and wants, fears, just like anybody else.
Providing access to housing and services is the formula, right? Because that is what honors the truth. Everyone has the right, whether or not they have a justice-involved background, to a decent, safe, and affordable place to call home with the access to supportive services. Whether or not your motivation is fiscal conservatism or it's the right thing to do because we're all ensouled being and have basic human rights, it is a win-win for everybody.
In this country, which is one of the richest countries in the world, there should be no homeless. There should not be anyone in the streets.
I know you're saying, well, I don't want criminals living near me. As you've seen in this video, they make good neighbors, they make good tenants, they make good employees. They have served their time, they don't want to go back, so they're doing everything they can to stay out of prison. This is an amazing program, but it's only here in Ohio. We need you to reach out to your legislators to expand supportive housing where you live. As you have seen, supportive housing saves lives, saves taxpayer money, and it reduces homelessness. It actually is the only permanent solution to solving homelessness, and one of the biggest causes of homelessness is people leaving jails and prison with no place to go.
The U.S. continues to.
So as you saw in the video, it affects everyone, not just those that are coming out of incarceration. It affects your neighborhoods, it affects your families, and housing should be a right. Everyone should have the right to safe housing. And I am complete. Is there
lead the world's
for me? She's trying to get the the PowerPoint back up. But are there any questions?
Incarceration rates.
No one? Well, I thank you all for letting me come and present about RHO and CTP. And she has, the PowerPoint has been to you, and it has my contact information. And it also has the link if you would like to watch the whole documentary. And then there's also a podcast that goes along with the documentary. And thank you, Justice Stratton, for having us.
It is so exciting to see what has happened with returning home, because when I joined the National Corporation for Supportive Housing, as I said before, I was co-chair of the committee that first started working on this, and then I brought the idea back to Ohio. And when the Attorney General, Mike DeWine, asked me to do the task force, he gave us $500,000 to incentivize some programs with our committees, and we took 250 of it to do a returning home program down in Cincinnati, which the Department of Corrections then took over. And you can see it truly is the least expensive way, but the most productive way to change lives. So, and what's up for the future? Very quickly, as I said, because of PEGS, we're not from the government. We're going to survive no matter who wins governor. Either Attorney General is very likely to continue the Attorney General Task Force, which I'm very excited about. I've made it through 4 or 5 different governors, Republican and Democrat, with not much of a glitch, and I expect to keep doing that with the work because we have so many wonderful partners in this, but everybody is so passionate about this issue. So again, I've given you back 3 minutes of your day, so go forth and do good works, and we'll probably see you in September. Thank you.